Good day, everyone. It's good morning, good noon, and good evening to wherever we are in the globe. This is Leonela Ocampo of the Philippines. I am a pharmacist who had worked across different areas of pharmacy practice. And this experience of working in the different areas of practice gave me actually a view of how pharmacy services and pharmacy practice happen, especially in my country. Then I also had served in the National Organization of Pharmacists in the Philippines, the Philippine Pharmacist Association, in different capacities. So I chaired different committees and served as its president for 2 terms, and that was for 4 years. As president in that period, we have introduced a number of changes in the operations of our organization, from structure to its operation, and successfully had worked for the passage of the new pharmacy law. I also was working as a member of the Technical Committee for Pharmacy Education of the Commission in Higher Education, and a member of the Continuing Professional Education with the Board of Pharmacy Professional Regulation Commission, and one of the technical experts of the Technical Education for Skills and Development Authority of the country. So we have a very important and a very interesting topic today, titled Long COVID and Pharmacy, Managing the Long-Term Effects of COVID-19. Long COVID, you and I know, also known as post-COVID-19 condition, is estimated to affect 10 to 20% of the people who develop COVID-19, while the majority go on truly or fully recover. This group of people suffer a variety of physical, physiological, and cognitive symptoms for many weeks, months, and sometimes longer. The condition could be debilitating, and recovery requires a holistic and personalized care approach, including pharmaceutical care. Our event today, as is provided to us by FIP, aims to explore in more depth what long COVID is, what the key characteristics and symptoms are, and how the symptoms can be managed in the pharmacy. The panelists we have include a public health expert on long COVID-19, a clinical pharmacist who is recovering from long COVID, and a physiotherapist, and we have more. The learning objectives of our activity now are the following. One, we want to describe the key characteristics and symptoms of long COVID-19, try to understand the latest research and evidence concerning treatment and care. Third, we would want to discuss ways long COVID symptoms can be managed in the pharmacy and identify the importance of pharmacist understanding of the condition and the care needs. And we would like to have some housekeeping announcements in it. This webinar is being recorded and live streamed via YouTube. The recording will be available on our website. It's https://events.fip.org. You may ask questions using the question box provided, and you are welcome to provide feedback to webinars@fip.org. And I would like to invite everyone we have here, if you are not yet a member of FIP, enlist to become a member of FIP at www.fip.org/membership.registration. The webinar is sponsored through the unconditional funding of Helion. So Helion is with us in the conduct of this webinar. And before I would introduce our panelists, let us listen to the video from the World Health Organization that describes long COVID and how it impacts millions of people around the world. So let's all be listening to this video.
I think the first thing we all have to do is recognize that this exists to show solidarity and support to people who are suffering with post-COVID condition. There are all kinds of potential long-term consequences. If you've been in ICU, you've been on a ventilator, you've gone through the physiological, psychological stress of being in intensive care, you may suffer for a long time because it's a huge insult to your body, it's a huge insult to your mind. You can see that pathway and you can see why it can take people a long time to recover from the inflammatory stress and from just trying to survive for so long. People have this post-COVID fog, this sense of having brain fog, this lack of energy, this lack of exercise tolerance, and sometimes those symptoms are non-specific, but it's well recognized, it's been well documented that this exists. And when you consider the millions, billions of people who've been exposed to this virus, it means that we have a significant number of people suffering with various forms of post-COVID condition. And that could be physiological and physical, it'd be psychological and psychiatric. There are so many long-term impacts of this. It's really important that we show that solidarity and we stand with people and bear witness to what they're suffering and then find the resources to support them, that we reach out to people who are suffering. Everyone has suffered in this pandemic. It's okay not to be okay. People have gone through a lot. They've experienced a lot. And it's really important that we stay open and people are able to express their emotions, express their feelings. And that's not rejected as, oh, we just got to move on now. Because we're going to leave a lot of people behind.
Okay, so after hearing that and viewing that video, let me introduce quickly our panelists today. So we have three in the lineup. We have Dr. Lizette Sisik, Rani Kativ, and Darren Brown. They will be introduced formally each. I would be introducing them one by one, as we call them, to give their sharing of the discussion for tonight's or today's activity. So let me first introduce our first member of the panel. We have Dr. Lucette Sisik. Dr. Lucette is an associate professor and a neuropsychologist with extensive neuroimaging training, who leads a research program into the neurocognitive complications in two major infectious diseases, COVID-19 and HIV, at the University of New South Wales, Sydney, Australia. Dr. Sisik has expertise in the measurement of cognitive trajectories across the adult lifespan in longitudinal cohort studies and clinical trials. Additionally, Dr. Sisik is chair of the International Neuropsychological Society Neuro-COVID-19 Special Interest Group and the neuropsychology leader of the landmark ADAPT COVID-19 prospective study at Sydney St. Vincent's Hospital. Dr. Sisik has had major international and national research responsibilities and associated funding. She has led the research on more than 30 national and international cohort studies or trials as a neuropsychology or neuroimaging leader. Fellow pharmacists, let us all welcome Dr. Lucette Sisik.
Thank you very much for this introduction. So I would like to thank the International Pharmaceutical Federation for inviting me today on this very important topic of long COVID. I hope that you will find my talk useful. So next slide, please. So far, the literature that we have out there has really concentrated on the severe consequences of long COVID. Even in the talk that we just had, the little video we just had from WHO, The person was talking, the doctor was talking about, going through ICU and having consequences from this. But the truth is that most people who have been infected with COVID have not been through severe disease. Most of them have been asymptomatic, and then a lower number have been mildly symptomatic to moderately symptomatic. So then in the next slide, please. In the next slide, what I want to put the attention on is that the idea that some of the factors of mild cognitive impairment that we see as part of long COVID are due to the initial confusion, due to the initial disease severity, to the therapy that was given during ICU stay. And this other type of invasive treatment is actually not relevant anymore. What's relevant is the cytokine storm that takes effect during the moment of infection and closely after, and then how the body reacts to this cytokine storm, and how much the immune system becomes dysregulated chronically. And some of the difficulties that people are experiencing are mainly attentional concentration difficulty and psychomotor slowing related to fatigue. They're not severe type of cognitive deficits. They're the kind of cognitive abilities that you need when you concentrate really hard on something. So you're still able to go about your daily life, the minimal things you can do. But if you have to do something like cognitively intensive, you will have difficulty. So we far from, for the most majority of people, we far from a condition that is very severe cognitively. And I will give more information about that. So next slide, thank you. So what's important when you read the literature about the post-acute COVID cognitive impairment and decline when people do longitudinal study is that you have to remain critical of how those studies were conducted. So there are important aspects in whether people are able to detect more or less cognitive deficits in their studies. The first thing is what are the clinical characters of the sample? What are the medical, psychiatric, and psychiatric comorbidities? Have the cognitive tests really corrected for major demographic effects such as age, education, and it can be also gender, and in some places there needs to be more correction than that. Have people use standard objective testing? Because often if you just ask people, if they've got cognitive difficulty, they may say so, but you need to prove it on an objective testing. Have people included people with very severe disease or moderately severe disease or mild disease? Were those studies only cross-sectional or longitudinal? So do we see the cognitive impairment fluctuating over time, or is it stable? And then the next thing is that we've seen a number of very large studies with hundreds of thousands of patients that have been published recently and have had a lot of press. So I think we have to be relatively critical about those studies because some of them are based on not very sensitive tests for mild cognitive deficits. So in other words, I would just want to emphasize again that most patients are asymptomatic or have mild COVID disease. So the cognitive change, if it's reliably proven in this population, in the wider population, would have a serious consequences in terms of public health, given the global prevalence of the infection. I am not saying that the people who had severe disease are not important. What I'm trying to say is that we need to take the measure of how many people have been actually infected and can actually develop long COVID independently of the acute disease severity. So next slide, please. So this is why in April 2022, I founded that group with the International Neuropsychological Society to re-emphasize the need to conduct rigorous studies and studies that account for certain numbers of factors in the way we look at cognition. So as much as it's an important topic and there is a lot of rush to publish data, we still have to do things rigorously. So that's why I created that group. Next slide, please. And so the group has published a recommendation for research and clinical practice in terms of how best to assess patients with cognitive difficulty related to COVID, and what to do in terms of studies. For example, if you do longitudinal study, how to correct for practice effect. And also because it's a global situation, so recommendation on how to adapt tests cross-culturally. And so that platform that we have is for neuropsychologists mainly, but it's open actually to more to outside the neuropsychology world, providing you a member of our society. But we share protocol methods, and we promote international research. We have a strong consideration, as I said, for neuropsychology across the world. We want to focus more now on long COVID, because this is really what's concerning everybody. And we want to try to use the RECOVER study in the US as a model, because it was informed that in terms of cognition, it was informed by our recommendation. Next slide, please. So I would like also to highlight the COVID neural network, which I'm part of. But for this COVID neural networks, I actually developed a standard neurologically form to collect information about neuro-COVID, and there's been publication associated with it. And so if people are interested in doing research, you can also use our recommendation as well as the neuro-COVID recommendation. They've kind of been merged in our recommendation. Next slide, please. So here at St. Vincent's, to sort of concentrate on a milder level of infection. So we looked at people who were prospectively seen at Sydney St. Vincent's Hospital. All patients, including all patients who had a COVID PCR result, is still recruiting now, above 18-year-olds, people who were able to consent. And so the aim of the study was multidimensional, but included a cognitive and an olfaction testing. And then because we had experience in chronic dysregulation because of our research in HIV, we selected several biomarkers, and in particular the Kinnear pathway. Next slide, please. So the ADAPT study aim was to determine the prevalence of cognitive impairment, trajectory of overall cognitive performance, corrected for age, education, and sex, like I've explained earlier, that because it's important, and the clinical significance via the assessment of functional impact of COVID-19 cases who recovered mostly from a mild to moderate acute infection across the 12-month period. And I have to emphasize that even the people who had, the few people who had severe 10%, who had severe acute disease, in fact, none of them died, even if they went to, I mean, I'm saying this lightly, it's not light to say that, but so none of them actually were deceased and they're still alive today. So it's just to say that even if they were severe, they were not amongst the most severe cohort either. So the idea was also to elucidate the pathogenesis of COVID-19 associated cognitive impairment and function. We wanted to assess a range of blood cytokines that we knew were important in the upregulation of the immune system, some peripheral biomarkers of brain injury that have been known to detect brain injury in the blood, and some metabolic product, the Kinnear pathway. We also looked at acute systemic disease severity, lung function, objectively tested olfaction, the pre-existing illness in terms of psychological health and current during the acute phase, medical comorbidities, and also how people perform initially on their visit. So we try to actually emulate the recommendation that we wrote by adjusting for a lot of factors. So next slide, please. Okay, so that's the study sort of design. So I'm just not going to spend too much time on it because it's actually doesn't render very well here. But just to say, we had 128 people at baseline in this analysis, and so if, people went through 3 neurocognitive assessment, 2 months post diagnosis, 5 months post diagnosis, and about 12 months post diagnosis. And so they did at the same time, and in additional one, they did also blood testing. We also had session regarding mental health at the same time as the cognition. We looked at lung function in a subset, and we have an immunology study as well that has been published by my collaborators in a subset as well. Next slide, please. So if you can press again next to, just to make appear the images, thank you very much. And next one. Yep, so that's the test we use. We use the widely recognized Cogstate test battery, and it's really a step up compared to some of the tests that have been used, such as the MOCA or the MMSE in those very large studies. The Cogstate has been not only designed to test people across time, but is also culturally fair. So that's an important aspect. And so this test comes with a large number of correction for age, education, and gender. And we have here in Australia developed also correction for practice effect. And so this test actually taps into what long COVID people with long COVID report in terms of difficulty attention, psychomotor speed, and really strong sort of active sort of memory type of new learning, so things that are quite cognitively demanding. And then we also included the NH Toolbox olfaction odor identification test, which is also corrected for age, education, and sex. And it tests on an iPad up to 9 smells, and people have to scratch it and smell it, and they have to pick the one they think it is on the 4 images. Next slide, please. And then, so we used some screen for mental health, because you have to imagine that the people were also assessed for many other numbers of issues. So we had to try to do screens rather than doing a massive assessment for each issue they may have. Anyway, so our mental health really concentrated on depression and anxiety, and we just collapsed that into one big component because it was highly related. Next slide, please. So the Kiernan pathway is a metabolic pathway of the tryptophan. It is typically dysregulated by chronic inflammation, and it may contribute to COVID-related brain dysfunction. The Kiernan pathway has been involved in various different conditions, but when it's sort of mildly upregulated, it's been involved in sort of infectious disease such as HIV, and it's been actually, there's been several publications showing it was actually important in the case of COVID-19. So next slide, please. We quantified, I will refer to you the preprint, because this is some technical things that, the way the quantification was done for the KP metabolite, but you can look that more carefully in the paper. So next slide, please. Okay, so the samples demographic. So what we had as demographic, we had people who were in the mid 40s. They were fairly well educated because of the hospital catchment area in Sydney, which is affluent, which is a limitation of our study. We had a good representation in terms of sex, and in terms of ethnicity, it represented a relative good mix of what we see in the catchment area. In terms of medical comorbidity, 36% had some comorbidity, but all of them were very healthy in general. All the comorbidities were really well managed. Next slide, please. So what we found first, we found that across the timeline of the study, which is 12 months, so when we assess people at 2, 4, and 12 months, we find that 16%, and then 23%, and then 26% showed mild to moderate cognitive deficit. So nobody had severe cognitive deficit. So that's not what we see with long-term COVID. We see mild cognitive deficits that mostly affects psychomotor speed, attention, and active learning. But what we were surprised about is to see this sort of decline in across the 12 months period of the study. So I have to say that the decline was corrected for practice effect. So it's not only that people decline per se, it's that people fail to improve. And we know normally when you repeat neuropsychological testing or cognitive testing, you should show some kind of monotonous improvement, and we didn't see that. And it kind of reflects that we ask people to do something cognitively demanding, and they cannot go back to their top level. What's interesting as well is that independently of whether people had more or less, good cognitive function to start with, we also detected that a slow level of decline. So next slide, please. What's important as well is that we found that the initial severity of the disease was not associated with the decline. So everybody's declining independently of whether they were hospitalized or had very mild disease or moderate disease, which include 2 symptoms. And then next slide, please. And then, so what we found as well, when we looked at does this cognitive phenomenon has any impact in real life terms, that we did find that it did. So we found that at 2 months and 4 months, people who were cognitively impaired according to our criteria, which detects at least mild cognitive deficits, were less confident of returning to work at both time points. Next slide, please. So interestingly, because so what's happened when something mild like this happen, and we have the experts in HIV, is that unfortunately the patient often experience dismissal or minimization of the symptom. It's that, well, it's all in your head, and it's probably depression. Well, actually, what we see is that the mental health symptoms were relatively elevated, somewhat elevated, 27%, but across the study timeline, they actually decreased. So, and then when we corrected for even the presence of those deficits in our models, that did not explain anything. So saying to a patient, it's in your head and it's because you're depressed, is actually not correct. At least when we talk about this mild level of deficit, and there's always going to be case-by-case situation. Next slide, please. And then, so what we found is that the kynurenine pathway was upregulated. So in other words, there was an association across time with the main neurotoxic or neuroinflammatory product of the kynurenine pathway, which is the quinolinic acid, as I shown there. And so, in other words, what's important is that also when it happened about 2 months post-diagnosis, there is an elevation of the kynurenine pathway, which is actually linked with other biomarkers. I will show that a little bit later. And this elevation actually persists across 2 to 4 months, and then obviously decreases in most people. But I think it's enough for us to determine that the immune system has been upregulated to a large extent across the board in the sample, including in people who had mild disease. So next slide, please. And then, so what we found, and we're the only one who have found that so far over the world, and we're trying to publish the result finally in a final scientific paper. It's only in preprint at this level. We find that the neuroinflammatory product of the kynurenine pathway, which is the quinolinic acid, was actually elevated across time as a function of poorer cognitive function. So in other words, one of the main and actually the only factor that explains that level of mild decline that we see. So people are not declining towards severe cognitive deterioration. Okay, that's important. They're just not as good as what they should. We see that this mild decline is actually correlated with this upregulation of this metabolic pathway. Next slide, please. And then, so what we did, we went to look further. We also had data from people with other type of coronaviruses. We had data from people with chronic fatigue syndrome, healthy control, who also had done the kynurenine pathway. And we show here that the people who actually had impaired cognitive function at 2 months here and had an upregulated kynurenine pathway actually were cognitively impaired, had a higher upregulated pathway compared to every other type of sample, including the one with chronic fatigue syndrome. So next slide, please. So what we see overall, I'm trying to kind of give an overview of the result. When we looked at the data internationally, when we looked at our data, including our colleagues, the immunologists who looked at interferon beta, and they found that interferon beta was the culprit in terms of the upregulation of the cytokines. So what we find, and including in our paper, is that when people have very severe disease, there is indeed an involvement of those peripheral neuromarkers, but we didn't see it in our study. What we saw, however, is a slight upregulation of the IL-6, which then it's known to be linked to interferon beta. And interferon beta is a mediator of the current pathway. And we know that the current pathway actually activates monocytes, inactivated macrophage and macroglia. And it's a plausible sort of biological pathway for mild, moderate cognitive deficits, not severe deficit, mild to moderate cognitive deficit that people experience. And this is why sometimes it is dismissed because it's mild, but we have a plausible immune involvement behind what's going on. Next slide, please. And so I just want to give the take-home message. So in our study, the current pathway was activated actually it's more like 2 to 4 months in particular, and then decline across the 12 months post-diagnosis. The current pathway, the quinolinic acid, was the most dynamic, that sort of curvilinear profile that we've seen, and it was associated with lower cognitive performance. The association between quinolinic acid and cognition was independent of comorbidities and disease severity. And so both quinolinic acid and the quinoline tryptophan ratio may represent a neurocognitive signature of Neurocovid. We're not sure about that. We need more assessment of this. But anyway, so the current pathway may be useful in monitoring and elucidating COVID neuropathogenesis and treatment. I've linked the preprint here, but it's just to show that, again, in this type of the little design that I've made here is kind of a summary, take-home message to show that the anxiety depression was not explanatory of our finding. Rather, it was an upregulation of the current pathway, which is itself linked to the dysregulation of IL-6 and interferon beta. Next slide, please. So that's our team. We have a big team because it's always like that in research, and thank you for to the participant because they get a lot of time. And the next slide, please. And so I've linked here some resources for whoever wants to follow. Some of the resources I've used to do the talk, and those resources are actually getting updated all the time, and they're very useful if you want to follow the literature. And next slide, please. Thank you for your attention. I probably would further than my time.
Thank you very much, Dr. Lucette. So before we go and hear from Running, we'd like to show you another video from the World Health Organization on patient stories and experiences with long COVID.
I'm Alexandra. I work in an energy company in Vienna, and I've had long COVID since 2 years, since the end of August 2020. What was the most interesting to me was this feeling of fatigue or tiredness that I've never felt before. Your whole body is so heavy. The overall recommendation was you'll get well, you're young, you had a COVID infection, and things kept getting worse. The scariest thing was that nobody knew what was happening. I was off work for 9 months in the beginning, then I started a phased return, I had to interrupt it, was off work again. Back then I was running a department, and I realized after 1.5 years of long COVID that this is something I cannot do anymore.
My name's Molly. I'm a hospital physiotherapist who works for the long COVID team and contracted COVID in May 2020. Having done a 5K run 2 days prior, I woke up one morning with a horrendous temperature, a headache, extreme fatigue, and I got to the stage where I couldn't leave the house. I lost all confidence in my body, and it didn't just push back on my physical health, it pushed back to a degree where I lost myself and I lost my identity. But I'd say my rehab took over a year to start introducing what I would class as more intense, even moderate intense activity, where I wasn't getting a kickback of this flattening of fatigue. I saw a psychologist quite early on, which is one of the significantly important things that happened in my rehab.
If you look at me, you have no idea I'm ill, and this is the case for many of us. I'm very lucky with my job and with the country I live in, because I obviously had financial worries. There was a time when I wasn't sure I would be ever able to work again. People who want to work cannot work anymore, and we want to contribute to the society. So acknowledge it, listen to us, and help us find solutions.
I now work in the long COVID clinics as a physiotherapist, and we provide assessments and then management strategies for giving a holistic approach to sort of managing the long COVID symptoms that people are getting. I think this is literally the tip of an iceberg. I feel like we are only scratching the surface of the degree of the problem that we have with the survival of people who have suffered with long COVID. And I'm quite proud to be that person that hopefully can give other people hope and motivation that although there's some very dark times, there can be a light and you can find your identity again.
So thank you. Thank you. It's really nice to hear from patients who have had COVID, who generously shared how their experiences were or are when they have had that disease. Now we move to Dr. Rani Katib. Dr. Katib is a frontline senior clinician and an accomplished academic. He is a COVID-19 survivor. He leads several cardio-renal metabolic innovative clinical services and is a national clinical champion for lipid management at NHS England. Dr. Katib is a member or chair of several national and international committees, including NICE Heart Failure Quality Standards, European Society of Cardiology, and UK Clinical Pharmacy Association Cardiology Group. He is well published and leads several applied research projects. Dr. Rani is unable to join us live today, but he has generously sent us his recorded presentation. So we'll listen to Dr. Rani.
Hello, everyone. Thank you for the opportunity to talk to you today. My name is Dr. Rani Katib. I'm a consultant pharmacist in cardiology and cardiovascular research and an associate professor at the University of Leeds. It's my pleasure to share with you my experience of long COVID firsthand, and also try and reflect of the potential role of pharmacy based on my personal experience. I don't intend to copy paste what we have in the literature or what people speculated about the role of pharmacy. I would like to share with you my point of view and where I think pharmacy could play a role in supporting patients with long COVID. So to start with, I'm going to just talk about my experience. I had a really bad battle with COVID. It started with a simple headache after contracting the virus. Moving on to a lot of coughing, a lot of fever, and things have escalated severely. And I, within a short period, had multiple PEs. I was becoming bedbound, could not breathe. And within weeks, I was in intensive care. I was intubated. And I spent nearly 3 months on intensive care. Of course, I was out of it. I can't remember a lot of what happened with me on intensive care, but I had a really terrible experience that my family witnessed. I ended up with a complete multi-organ failure. We are talking about complete renal failure, talking about pneumothoraces, severe anemia, and peri-arrest, and ending with a complete cardiac arrest, which I had to be resuscitated to be brought back. It was a very severe battle, and after 3 months, I miraculously survived because my chances of living were very, very slim. And I was transferred from one hospital to another in order to receive care, and I recovered in hospital for months and months, and I needed extensive, long, complex rehab to bring me up to speed so that I can relive my life. So my experience of long COVID is going to be combined with my intensive care stay, combined with my long hospital stay. I'm talking about months, which of course had severe consequences as well. So while I'm speaking about this experience, please take that into account. So it's a bit of a mishmash of long COVID alongside the consequences of being on and the aftermath of being on intensive care, and also the aftermath of being admitted in hospital for a very long time. I've deconditioned massively. I have to rebuild my muscles. I've lost, about 40 kilos. And I was very, very weak. When I woke up, I barely could move my head, barely use my fingers to do anything. And this is something that needs to be remembered, because people who have long COVID, they may not only be people with just long COVID, may also be suffering from the consequences of their long admission, if they had an admission, the long ICU stay, if they have stayed in ICU, and of course, all these complications could be implicated in chronic conditions that develop for patients after that, and I will highlight some of that later on. So I'm going to share some highlights, and then I will be talking about some of my experience. So I spent almost about 8-9 months or more in hospital. I was discharged. Of course, during my hospital stay, I had a lot of physiotherapy because I could not get out of bed, and I was completely bedbound after my deconditioning. So I was desperate to go home because there was a lot of lockdown. The visiting of family was not permitted. It has a huge effect on me psychologically, and this is something that you need to take into account when you are supporting patients who have had really terrible COVID admission, a prolonged one as well, because of the psychological impact of that, in addition to the physical impact, is really, really important to remember. So all healthcare professionals, including pharmacy workforce, need to take that into account when interacting with patients who are survivors of COVID or people battling with long COVID. Just a bit of technicalities, and I'm sure my colleagues probably would have touched on all these things, but in the UK, NICE defines long COVID as the symptoms that a patient or people experience for 4 to 12 weeks after an infection. So after the infection has gone, you continue to experience these symptoms, or you experience symptoms of COVID and other symptoms that cannot be explained by any alternative diagnosis 12 weeks or more after infection. And this is what we're seeing a lot of. And of course, this is seemed to be more seen in patients who probably have not had vaccination. And this is important to remember, is that the likelihood of somebody having long COVID, if they were vaccinated, seems to be slightly less than those who were not vaccinated. And it seems that the Omicron variant had led to less long COVID compared to the previous variants as well. There was a study published by King's College here in London where they looked at the different symptoms reported by patients who were experiencing long COVID, and it was pretty much split into 3 categories. The first is all around fatigue, and I can tell you loads about that, brain fog and headaches, and that's probably the most reported symptom, and then respiratory symptoms, mainly shortness of breath, some chest pain, probably seen more by people who had more problems with admission and maybe have been to intensive care. There was also diverse range of symptoms reported by people, from palpitations, which I can tell you about, muscle ache and pain, and changes in skin and other symptoms. This is the list of different symptoms that people report when they have COVID, long COVID. And I can relate to quite a lot of them, which I will share with you. Fatigue is definitely number one, and is definitely the most reported symptom. And fatigue is due to probably many different pathophysiology. We're not very clear about it, because even people who are not admitted to ICU, for example, still can experience a bit of fatigue. And the fatigue element is just really seems to be that you just run out of energy. So I usually would wake up in the morning full of energy, but my energy doesn't last. And within about a couple of hours, I'm really fatigued and I need a nap and rest. So you've got a bit of rationing of your energy that you need to manage. And there's this concept about pacing yourself. So you don't use all your energy reserves all at once. And you plan how you're going to spend your energy reserves, and you prioritize so that you focus on the things that you're going to be needing a lot of energy for. And that doesn't necessarily only mean physical energy, because you need also to take into account the mental energy that you need in order to perform some tasks. And I always give the example that I genuinely lived. And I'd say the best thing to tell patients about this is to explain to them about how we would manage with electric cars, where you've got a battery, the set up amount of energy in it, and then you need to make sure that you account for every element that you're going to burn that energy, you pace it, and you prioritize it, and you have a good plan in place. And this is probably also, there are some elements linked to the fatigue. If you have been in hospital and you're deconditioned, it does help a lot to have a lot of exercises. I can't praise my physios a lot in terms of how well they have done in supporting me and rebuilding my muscles. Of course, you need to make sure that you're having good diet, high protein intake where appropriate, in order to rebuild your muscles is quite important. The other element that probably the pharmacy workforce might come across is the breathlessness element. A lot of people with COVID and long COVID report breathlessness and shortness of breath. It does get better, but you do find it to be really limiting. And with exercise, it gets better. I guess sometimes it can lead to anxiety, and that can exacerbate it and makes it worse. It's all about staying calm. It's all about finding the best position that makes you breathe better, and having deep breaths and being relaxed. So these are practicalities. We may not really reach to some over-the-counter medicines to deal with it, but actually the counselling and supporting patients who experiencing these symptoms is really invaluable. Difficulty sleeping, it's a challenge, and again, it's advice to those patients what to do to have a clean environment, less intake of caffeine, etc. Dealing with anxiety, being slightly more irritated, all these symptoms you can have. Of course, you could offer some over-the-counter medicines that help with that, but generally speaking, the support on discussing these symptoms of how to deal with them, I found very, very useful. I have experienced palpitations where due to tachycardia, and it was sinus rhythm tachycardia. And in my case, my cardiologist recommended the use of Vabradine because my blood pressure was a bit low, because I lost a huge amount of weight, and it took me time to rebuild my muscles, and therefore my blood pressure was low to start with. Vabradine did the trick. Very important to remember that these symptoms don't necessarily last. Like in my case, I was tachycardic for nearly probably about 12 months, but after 12 months, my heart rate went to normal. So It's important to also keep an eye that this is not atrial fibrillation, so pulse check is really important, and it's something for you to think about. Chest tightness and pain, that's probably a combination of whatever was happening to the patient if they were to hospital, but also the breathlessness element, the deep breaths, the challenges that might have. Giving them some simple painkillers such as paracetamol might help, but breathing exercises are also helpful. Joint or muscle pain, I have experienced that, and I found that the use of simple analgesics such as paracetamol is useful. Always keep an eye on how the patient's kidneys are, because some people with COVID might end up with chronic kidney failure or acute kidney failure to start with. But always keep an eye and think about whether or not their kidney function is allowing the use of analgesics other than the paracetamol, for example, because non-steroidals generally would be probably not advised in this condition. In my case, the change in smell and taste has recovered pretty quickly, probably from contracting COVID. When I woke up after my intensive care 3 months, probably took me about 3 months to regain my smell, of 3 to 4 months. But I know that some cases persist for longer. And there's some articles that you can read about, some starting to publish things around things you can do to actually address that. Persistent cough was a big thing for me, and I have suffered from that. It was so limiting and distressing. At the beginning, it was a slightly productive because of all the intubation that I had, and I had tracheostomy as well. So at the beginning, it was productive. I needed a lot of carbamazepine in order to help me to bring up the mucus and make it less viscous. But as time went by, I needed some cough suppressant because the cough was more dry cough and tickly cough. So the recommendation of products which calm down tickly cough was actually of great value and useful for me. Very important to remember that some patients with long COVID, and probably because of ICU admission, they might suffer from peripheral neuropathy. I had that, and that meant that my walking and mobility was not brilliant. I still have some mobility issues, and that's probably attributed to my long ICU admission, my deconditioning, but also some neuropathic physiology or pathophysiology that led to my mobility being limited. The use of medicines to deal or treat neuropathic pain is something that you need to brush up when you manage patients who've got that. I don't want to dwell into every single symptom, but this is just a highlight. The only thing I want to remind you, based on my personal experience, that not to forget complications that patients might have had during their admissions, such as chronic kidney disease, and also other new conditions that they didn't have. We know that some patients seem to be developed diabetes post COVID, and it's something to watch for. And usually your role would be about modification of risk factors and optimizing medicines. So to conclude, I think based on my personal experience, long COVID is highly debilitating, and it's really physical, psychological, and it has also cognitive impact. It does affect your quality of life, and you realize that now you are living with new challenges and disabilities, and you need to work with people to find out what their challenges are and how you can support them. Some are transient, but some can be chronic. The pharmacy workforce need to address and support patients with troublesome symptoms, but also need to think about new long-term conditions that they might have developed, contribute to the long COVID MDT services, and working closely with colleagues such as physiotherapists, occupational health is really, really important and invaluable. To finish with, I'll be really happy to share more of my experience, and I am planning to write my whole journey and experience. So watch out for my book that I'm planning to publish to account for my experience. And thank you very much for having me.
Thank you very much, Dr. Rani. It's very nice to hear such a sharing from you. Now we will move to our next panelist, the third panelist we have, Darren Brown. Darren Brown is a cisgendered gay white man of English and Irish heritage, living in London, United Kingdom. Darren is a clinical academic physiotherapist and a fellow of the Chartered Society of Physiotherapy, awarded for global impact in disability and rehabilitation achieved through clinical, academic, and strategic leadership. Darren is a co-founder and inaugural chair of Long COVID Physio and International Peer Support, Education and Advocacy Patient-Led Association of Physiotherapists Living with Long COVID and Allies. Darren has contributed to national and international standards, policies, and guidelines on long COVID, episodic disability and rehabilitation, including World Physiotherapy and World Health Organization publications. Darren is co-principal investigator of a Canadian Institute of Health Research Mixed Methods Research Study exploring experiences of disability among people living with long COVID in Canada, Ireland, United Kingdom, and United States. Darren Brown will be joining our panel discussion. So let me thank you, Darren. Let me call Dr. Lucid to join us. Also, can you please open your, okay, thank you, Dr. Lucid. So, okay, I would just like to start with a question to Darren, but we will be entertaining questions from all of those who are with us joining in this activity, as we will take a look at the Q&A and the chat box and take note of the questions and then give it to you. So let me first throw the first question, Darren. So I would like to ask, what are the common physical symptoms of long COVID and how does long COVID impact physical ability?
Hello, and thank you very much for the invitation to be here. And also thank you to FIP and everyone that is listening, but also to those people that have presented before, both Dr. Lucette, who's here on the panel, and also Dr. Rani. And before I answer that question, I just wanted to comment on some of the things that were discussed, if that was okay, because I'm very appreciative for what has been presented. Not only is there wide diversity being reflected in the presentation of long COVID, from those people that have been hospitalized to those people that have been not, and have remained in community settings, but also in the wide diversity of symptom presentation, as has been shown here. And I think that what we have seen is that there are people that can have post-intensive care syndrome, or PICS, which is very clearly defined syndromes. And there are people that can also have, overlapping with that, presentations of long COVID. And as Lucette demonstrated, including mild to moderate cognitive impairment. And I was really appreciative of some of the ways that that was presented, because actually what was very clear from that data is that there's a pathological process behind the underlying mechanisms that are happening. There's a metabolic disruption that's causing this cognitive impairment. It's not based on mental health. It is also not okay to invalidate people's experience and create processes of testimonial injustice and gaslighting. And so I was really appreciative of that evidence, and I really hope that you get that published in a peer-reviewed paper soon, because I think it is very important that that is there. And I think that off of what Dr. Rani said around the incredible diversity of symptoms that he experienced, not only from post-intensive care syndrome, but also longer-term consequences of COVID-19 and how that overlapped and may be complex to know, I think it's really important that we do understand that there are many, many symptoms that have been described. Already in the chat box, people have been posting to the Davies et al. 2021 paper, which was published by the Patient-Led Research Collaborative, where they described over 200 different symptoms. It's at this point that before I talk about those symptoms, I want to recognize the involvement of people living with and affected by long COVID in the responses to long COVID globally. It was people living with and affected that named this condition. This has never happened at any time in history before, where patients stood up to raise the visibility of this condition. And it was our Italian colleagues that did that first, and naming this condition long COVID. And I'm really pleased to see that this name is still being used in this presentation. We know that the World Health Organization has provided us with a clinical case definition, and they're using the term post-COVID-19 conditions. And that clinical case definition is available. And they are continually updating their clinical guidelines. And most recently, in their most recent version this year, they've included rehabilitation guidelines. So in terms of what I want to reference with this is that there are so many symptoms. Everybody's experience is multidimensional. It can often be episodic in nature and even unpredictable with that episodic fluctuating picture. But there are some common symptoms that are repeatedly experienced by some people, not all. Some of those common symptoms have already been discussed, such as fatigue. I think in the English language, it doesn't do justice to the incredible disability that is experienced by people experiencing that symptom of fatigue as an overwhelming sense of exhaustion that completely impacts on a person's ability to physically function at the most basic level of instrumental activities of daily living, such as washing and dressing and moving around. And then there is the cognitive impairment that Lucette has so kindly given us a really comprehensive insight into in terms of some of the hypothetical pathophysiological processes that are underlining that. And even though it may be at the categorization of mild to moderate, for many people that are living with long COVID, they're of working age, they're young, and when living with mild cognitive impairment, it's incredibly difficult to be able to function in your usual roles when you cannot process words, when you cannot remember tasks, and when you have a difficulty in executive functioning. So we've got two symptoms there that are commonly seen, but there are also symptoms that haven't actually been discussed today. And I want to recognize that some of these symptoms are overlapping with a condition called myalgic encephalomyelitis, or ME, also known as chronic fatigue syndrome. ME/CFS can be an outcome of long COVID, and some of those symptoms are commonly seen. For example, we are seeing people that are having post-exertional symptom exacerbation. This is a symptom that also be known as post-exertional malaise. This is where there can be a delayed onset in a myriad of different symptoms after physical, cognitive, emotional, or social exertion. Another area that people are having symptoms is orthostatic intolerance. This is where people are having difficulty in upright positions. So it might be sitting, it may be standing, and they are having challenges with their heart rates and their blood pressure. So it falls under the umbrella of dysautonomias, but also a particular condition called POTS, or postural orthostatic tachycardia syndrome. Now, you asked one question, which is some of these common symptoms, and I'm not going to go through over 200 of them, but there are 4 just there that even in themselves are complex. And so to come back to that point I mentioned a second ago about the value of people living with and affected by long COVID in the responses to this pandemic, look at how much research has been published by community members. Look at the advocacy that is changing the responses to the recognition, visibility, and actions to healthcare, research, and funding of these different responses. And so the first thing I will say to any healthcare professional is believe the lived experiences of the person in front of you that says they're living with long COVID, because they probably have more experience than those that don't, and therefore can give insights and reflections that when you invalidate those experiences, you will miss out on.
Beautifully said.
Oh, you're on mute. Leonela, you're on mute.
Thank you, Darren. There are some questions that we have in the Q&A box. So let me read one from Riches 74. How effective is COVID vaccine to prevent long COVID?
I can take that if you'd like. The evidence is really varied and mixed. We were very hopeful early on that maybe vaccination might prevent long COVID. Unfortunately, that isn't necessarily bearing out. We have varied estimates that range. I could give you them, but it's a huge range. What we know is that unfortunately, people are still developing long COVID after many different vaccines of various types, and whether you've been double, triple, or quadruple vaccinated. So we are seeing people still develop long-term sequelae, long-term consequences of COVID-19 infection, even when vaccinated. Another important nuance to this, though, is that people living with long COVID are getting vaccinated. And so there's also an impact that some people are having. There is wide variation in terms of the impact that vaccinations are having on people living with long COVID, but you can fall into three groups, which is your symptoms can get better, your symptoms can remain unchanged, or unfortunately, your symptoms can get worse by vaccination. I was one of those very lucky cohorts where every single vaccination I've had meant that my long COVID got better. But as I say, I was one of those lucky ones, and that is not the experience of everybody living with long COVID who has received vaccination. So I think we need to be clear that we know that vaccines are really good at hopefully reducing death and hospitalization. However, in terms of us all being disability inclusive, we are not there yet to say that vaccines reduce disability in the context of COVID-19. So the best thing we can do is prevent getting COVID-19 to prevent long-term disability.
Thank you. Thank you, Darren. Luzette, do you want to say anything?
Yeah, I just think, I mean, that was great, Darren, what you just said. What I would add is that here in Sydney in Australia, but across Australia, there is some definitely denial that this condition exists. And I think that's a really, really problematic issue. But it's not the first time that historically we are in a situation where people deny the existence of a chronic condition that affects probably in a complex way immune function. So I personally, having worked in HIV for many years, I am not surprised to see the variation in symptomatology, because everyone's immune function is very subtle and very specific. So I'm using a very general term, so for everybody to understand. And so they also link to our strengths and weaknesses in different ways, such as cognitively, physically, etc., or respiratory, cardiologically, etc., or those strange symptoms that we have in our skins, etc. So I am not surprised that to see this range of symptoms, but I think by some people it is used as an excuse to say, oh, look at that, there's so many stuff, it can't be possible. Well, actually, no. When the immune system is engaged, you can't see this sort of things. And then what Darren was saying is that I'm not surprised that the main key symptom of fatigue, cognitive difficulties, this totally makes sense, and because I presented on mild, moderate cognitive impairment, I want to reemphasize that I am aware that some people have actually experienced much more significant cognitive deficits, and one of the things that we haven't talked is anosmia, loss of sense of smell. We had cases here in Australia of people losing their sense of smell for more than 2 years. And slowly recovering, very slowly only. So that's another one. And the last thing that I want to say is that the dismissal of and the minimization and dismissal is what eventually makes people mental health go down. If people are empowered and if we all find solution to try to work on understanding better what is long COVID, and making feel patient listened to, we will avoid also a lot of mental health suffering as well. We have seen this through multiple sclerosis that used to be, people were told it's all in your head. We're seeing this now sometime in the context of HIV, when people are aging and start to develop cognitive problem. People say it's all in your head. It is not all in your head. It's a complex effect of the immune system that is either upregulated or is chronically affected, so it affects other major function in your body. Last thing I wanted to say, sorry, it just escaped my mind because I got over excited there. But
Thank you.
Yeah, I just think I think what I want to say is that we need more research. Okay, so I agree with Darren as well. The vaccine situation is not clear, and I think it's like everything us as I guess as a medical community, but also as humans, we tend to be sometimes really good at responding to acute situation, but when it's become chronic, it's like, oh, it's too complicated, we don't want to think about it. No, actually, that's when we need to redouble effort to trying to find solution. And I just want to say one last thing. I remember I had one question across the Q&A about Well, if your Canaan pathway is abnormal because it's a tryptophan pathway, just take more tryptophan and all you've sorted. Actually, no, unfortunately, it is not that simple. In our study, the tryptophan was not altered. So you can have an abnormal quinoline pathway without having an abnormal tryptophan. I know it's complicated, but that's what happens because of the complex interaction of the at which level the enzyme actually affect the pathway. And the other complexity is when actually the pathway is activated. Obviously, what it shows is that there's a window of opportunity. There's a window of opportunity before the pathway gets too activated. And it might not even be the current pathway that we need to treat there. It's just what happened exactly just before. So that's why it's complicated.
Thank you, Lucette. Another question for Darren, very specific for Darren. What is the role of physiotherapy care in managing long COVID?
Yeah, thank you for that. So physiotherapy is a rehabilitation professional. And if we're clear about what rehabilitation is, it's about addressing impairments, activity limitations, and social participation restrictions in daily life to optimize function and independence. I want to be explicitly clear. Physiotherapy is not synonymous with exercise alone. And I was really appreciative that for some people, such as Dr. Rani earlier, he expressed how having gone through intensive care and experienced post-intensive care syndrome with deconditioning, he required exercise interventions. The majority of people living with long COVID haven't touched a hospital and have never been in intensive care. And the majority of those people are by no way deconditioned. In fact, we have cardiopulmonary exercise test sequential data demonstrating that people are not deconditioned. And it doesn't make sense to be well one day, get COVID, and then suddenly become deconditioned. It doesn't make any sense. So I think that what physiotherapy can do is it can be bespoke. It can be individualized. And for those people that require exercise where it's safe and effective, that can be provided. But if you're experiencing symptoms like post-exertional symptom exacerbation, you can't exercise your way out of that because exertion itself makes your symptoms worse. That is why myself and many others have worked with World Physiotherapy to deliver their briefing paper number 9 on safe and effective rehabilitation in the context of long COVID, specific to physical activity and exercise. So when it is safe and when it is not safe to deliver that. And we've also used that as a benchmark for the World Health Organization's rehabilitation guidelines for long COVID. And what's great about those rehab guidelines is that there is a specific section for many of those common symptoms and an approach on how to address that. Something that's very clear is that pacing is a safe and effective strategy for many people that are living with post-exertional symptom exacerbation and other symptoms such as fatigue and cognitive impairment. And pacing is complex to understand, describe, and do. The most simplest way of understanding it is the balance between rest and activities. Rest is not a dirty word. Rest is part of our balance. And so therefore, if we are going to be aiming to try and help people get better, we need to support people through learning and adjusting to have purposeful, meaningful, productive rest in their days so that then they can balance their activities that doesn't exacerbate and flare up their symptoms. There is no such thing as pacing up activities. Basically, what we should be describing is a titration of activities. What we mean by that is this balance. So our activities can be titrated up and down, just like our rest can be titrated up and down, dependent on our symptom presentation. And because symptoms are wide, varied, multidimensional, and individual, and often episodic in their nature, and sometimes delayed in presentation, it can be really difficult to navigate. So I've given you a really long-winded answer, but physiotherapists can help people with addressing their disability, along with the multidisciplinary team, such as occupational therapists, whose bread and butter is cognitive rehabilitation and pacing and the provision of aids and equipment to support people with their daily functioning. Physiotherapists can be part of that, but I want to be clear that we need to be making sure that we are safe and effective in our rehabilitation prescriptions, and therefore that does not mean that it always is exercise, because for some people that can be harmful.
Right.
Thank you. Thank you, Darren. There's a very simple question that we find in the chat box. Please enlighten us. It says there, what exactly or how exactly is long COVID-19 defined?
Well,
What is the clear
I
definition?
can start to answer that, and then Darren
Yes,
can have.
Lucia.
The truth is that, first, I think we should acknowledge that it's a definition in evolution that is constantly evolving. Okay, so the truth is that by definition, there are some knowledge that we don't have yet because we only 2 years and so after the start of the pandemic. So unfortunately, I predict that some people will suffer long COVID consequence way longer than that. So we should not say our long COVID is exactly 3 months after post-infection. It's just that's not present like that. And it links again to what I was saying earlier, when there's chronic dysregulation in the immune system. It links to what Darren was saying in terms of the fluctuation, the episodic nature of the issues, and also the flare-up, sort of, which seems sort of unlinked to the original episode. Something happens way longer, after the post-diagnosis. So I think all of this temporality has to be recognized. And that's why I'm someone in my research that pushes for longitudinal studies or longitudinal research, which demands a higher level of funding and consistency across time. But I think that's necessary. However, that said, I think I would try to keep in line with sort of the main sort of bodies such as WHO, and because they're constantly actually adding up to the definitions. So if I would do a research study or if I would see patient, I would try to keep in particular in touch with one of those definitions to start with, but still with a critical appraisal, because this will change. Sorry, maybe it's a bit.
Thank you. Thank you, Lucette. So I will read 2 more. I'll have 2 or 3 more questions because of.
Can I also add on?
Yes.
Can I add on to that? Thank you. And I agree with Lucette on that wholeheartedly, which is why I believe that appreciation of the episodic disability framework and episodic disability, which is actually a concept translated from the lived experiences of people living with HIV into long COVID, is valuable. In terms of definitions, yes, it's complicated. I can see that there's people arguing in the comments about, is it NICE, is it WHO? NICE came out with their proposed definitions early on, WHO have been more recent. I would say that probably the World Health Organization clinical case definition is the best working definition we have in adults. They're currently working on one in children and young adults, young people. It is not free from criticism, but I think that it's what we have. And I think that's it, in terms of having international consensus and uniformity in language. Yes, it's not free from criticism. No, it's not perfect, but it is something we have. And so I would say that my suggestion would be that that's what we're working on. It is going to be an iterative process where that will continue to be defined in the future. But that does make some challenges in terms of those longitudinal cohort studies. But one of the things that is really clear is that many people living with long COVID have not always been able to access testing. And so having a positive SARS-CoV-2 test, it should not be a criteria for entering a long COVID study, because the WHO definition specifically says that post-COVID-19 condition occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection. And we know that around the world, testing is not always equal or accessible, depending on the time frames that you may have contracted the virus and the geopolitical landscapes in which that was functioning.
Thank you, Darren. Given that, what do you think should what a pharmacist need to know, and how could pharmacists support? That is, after hearing all the sharings of our patients in the video and that of Rani. So what do you think, Darren and Lucette, do the pharmacists need to know and how do pharmacists could support?
I'm happy to jump in if you want, Lucette.
Yeah,
and I can come from the lived experience. Yeah. So I'm not a pharmacist. And so I think that that does give me some challenges in terms of answering that. But what I would add to this is that I think a lot of people living with long COVID are self-experimenting, and they're using over-the-counter medications because they are wanting improvements in their symptoms. And I am a prime example of that. I self-medicate bits and pieces to try and improve my symptoms in the past. And I've had varying rates of success with that. So I would say that probably one of the things that I would encourage pharmacists to do is have a really open, transparent and non-judgmental conversation about what people are doing and trying. Because in terms of where the long COVID community is at, they're very, very engaged in the research and often are experts in their condition by the nature of having to learn to advance their own experiences. And so there's a lot of knowledge out there amongst the community in terms of the hypotheses that are out there, whether it be about viral reservoirs, viral fragments persisting in the body, whether it be about hypercoagulation, endothelial dysfunction, immune dysfunction, microclotting, whatever it may be. And I think that some of the things that people are doing is using things like over-the-counter antihistamines, using things like aspirins and things like that, or other things to try and reduce clots. But I think it's about having that non-judgmental conversation with people about what are you trying, what are you doing, because that's where actually the pharmacist can provide the expert advice about drug-to-drug interactions, what's safe, what's not safe, and what may or may not be working for the individual in terms of their symptomatic profile.
Thank you, Darren. Would Lucette want to add something on that?
Well, so, I mean, all I can say is that I'm aware that there are many current trials, testing different drug potentially to treat long COVID. The complexity, again, is the multidimensional sort of aspect of the condition. I just think, I guess, to resonate with Darren, is that there is one thing that we need to do, like it's been done in HIV as well historically, is to make sure that the research incorporate the lived experience, so that some way of thinking around, how and when and the type of drug that can be useful are sort of that this diversity of experience is actually brought to the forefront and not denied a priori. Yeah, but because I'm not a pharmacist myself, I don't have any specific advice for pharmacists. I just I guess I can say from as a neuropsychological perspective that if people experience significant cognitive dysfunction and they want to be assessed, I think they should do it. They should definitely try to access a neuropsychological assessment. Unfortunately, those neuropsychological assessments are not easily found, even in high-income country, they're not always available. But what the neuropsychologist should do, it should work in collaboration with other healthcare professionals to find solution that will improve your function on an everyday basis. Yeah, I would keep an eye out. If I were a pharmacist, I would really keep an eye out on the current medical research in terms of the trials that are being conducted.
Okay, thank you, Lucette. I'll just have one more question. We still have 3 in the Q&A, but for time constraint, let's take this last question, although it somehow has a relationship with the other 2. It's both an appreciation and a thank you message to all of you, Rani, Taryn, and Lucette. The one writing here is thanking you for the opportunity to hear all this information into FIP for this webinar. But the question that she has here, let me see, it's correct. It seems like a lot of people have complained about back pain and hair loss. How could these symptoms be explained? Are they really due to COVID-19? If based on the previous definition, as was shared by Dr. Rani, how could we help the patients manage them? That's the first question she has. Then since most patients, number two, have experienced fatigue, naturally want to recover quickly from it. They had been using all possible vitamins and frontliners. So what could you advise for this?
Okay,
How could we help
I'm happy
the
to start
patient?
if useful. So
Yeah.
in terms of the first one, so those two specific symptoms, so pain, the one that was described as back pain, and the second was hair loss. Both of those has been described in terms of the Office for National Statistics data in the United Kingdom, which is probably the most sequential, longitudinal and representative data of people living with long COVID we've got in the world. Pain continues to be the third most common symptom, secondary to fatigue and cognitive impairment. So pain is not unusual. And that can be in any joint and muscle group. So I think it's something that people are experiencing, and I think it's something that we should be addressing in whichever way is most suitable and appropriate. I can't comment much on hair loss, but it is something that is being reported. I think we don't understand why that is happening, but it is happening. If there are problems with circulation in the body due to endothelial dysfunction or microclots, that could be a hypothesis around this. But underlying all of that, what's the immune dysfunction that's driving that? So there's a lot to be said with all of this. In terms of the fatigue, yes, people are using as many potential strategies as possible to address the fatigue because it is life altering. It is completely transformative and disabling for people when the majority of people living with long COVID are of working age. They're struggling to perform their daily functions, let alone participate in economy and family life. And we're seeing that the data is coming out that more and more people through the pandemic are now experiencing disabilities than before. And that prevalence may have something to do with the presence of long COVID as well as a contributing factor. So people want to be better. People don't want to experience these impairments and difficulties in their day-to-day life. So I think it's unsurprising that people are trying everything at their disposal. And so my recommendation for the pharmacist is to have that honest, transparent and judgment-free conversation about what people are trying. I think in terms of what we do see, though, is that in that struggle to return to normal activity and the difficulties that people face, people will often want to try and push through their symptoms by the very nature of wanting to just be better. And unfortunately, we often live in a society where we are prioritized by our productivity. And so therefore, it is very difficult for people to be able to prioritize rest and to balance their rest and activities and pace effectively. And for many people, that may even actually be a privilege based on their economic situation, their family situations. Mothers with young children will find it much more difficult to pace than someone that does not have children. Someone that's in an economically viable position that can take time off work will be able to pace better than someone that cannot take time off work financially. So I think in terms of what we can offer people is we can offer them the opportunity to recognize that rest and pacing can be useful in terms of giving our bodies the opportunity to try and recover as best as possible, to try and reduce the exacerbation of those symptoms and hopefully allow our bodies to get a little bit better over time. But we haven't got clear answers. And I think that's why we do need more research, not only into the underlying pathological mechanisms that are causing long COVID, but in terms of successful and effective, safe treatments as well.
Okay, thank you, Darren. I'll have the last question to Lucette. Is there any association between people returning to normal activity too soon after an initial infection, getting back to work, household activity, exercise, and the incidence of long COVID?
Well, I mean, I've heard about this anecdotally, but I actually don't have any knowledge of a good scientific data on this. Maybe Darren, you do?
So again, this comes down to counting long COVID. So because we don't have international data robustly and accurately counting long COVID, we don't actually have that longitudinal data following people through from their initial COVID infection, potential reinfections, their experiences with vaccines and their experiences with symptoms in the context of long COVID. So we actually don't have this data that can follow people through to robustly say what people's initial experiences were. But we do have, as Lucette says, lots of anecdotal data that those people that were unable to take a period of time to recuperate, to rest, to genuinely allow their bodies to try and recover from acute COVID, have been the people that often do go on to develop more symptoms later on. We need better research to longitudinally and observationally look at that, but we need that in concurrence with mechanistic trials. We need that in concurrence with treatment trials. So there are many, many questions, and I think that's an important one. My personal belief is that if I had rested better in my initial COVID recovery period, I probably wouldn't have developed long COVID, but that wasn't a choice because I was a frontline healthcare worker and was redeployed to intensive care.
Right. So I remember when I was seeing patients through our study, I remember saying to a young guy, because he wanted to, he was, especially young guy, he wanted to be strong and go back to work again. And I said to him, well, actually, the best way to adapt now is to rest. It's the other way around and not feel bad about it, right? But one stuff that I wanted to add, though, is regarding the question before, I think that a good rapport with a general practitioner is critical. As I'm really an advocate of longitudinal studies, I think there's a lot into taking a very careful medical history, having a good rapport with your GP. And so if you have a good rapport with your GP, those unusual symptoms they've never seen before in your medical history, they're more likely kind of to pay attention to it. And that's also what I would advise individually to people, to try to establish that good rapport with a general practitioner, so that when you start to develop alopecia or strange symptoms, that they're not dismissed suddenly like that.
We have a lot of other questions actually in the chat box, but we're actually running out of time. And we would like to thank all those who have given their questions, and also would like to thank our panelists, Darren, Lucille. So hopefully some other questions that are in the chat box are recorded by our digital events team, and answers would be sent to them, maybe through email or how whatever way could be given to them. But I would just like, before I end, to throw this, because this is, I feel, very important. There is a question of whether long COVID-19 it could have some effects on patients' comorbidities, and then we end after that.
Well, personally, I think yes. I think that's the whole issue. I think that plays into the dismissal. Some people say, "Oh, you probably have long COVID because you had diabetes before, you had this X and Y." Well, I mean, it's true that if you have already poorer health, that you may be more at risk of long COVID. But I think it's a bit of a circular sort of assessment sometimes, because the people who have poorer health also were frontline worker, were people who were economically disadvantaged, etc., etc. So there's this aspect, and then there is knowledge that long COVID actually precipitate a few conditions, including diabetes. So I just think it's a complicated issue there. But and the one that I particularly worry about is whether long COVID precipitates dementia. Again, the evidence here is complicated because unfortunately a lot of people have died. So the people who had dementia were actually most likely to die. So unless we would have very well done analysis correcting for the death rate, we don't have a good answer to that. But what I know from my experience in HIV is that a chronically immune dysregulated system is not good news for brain health. So that's why we need to develop strategies, both medically, in terms of intervention, to not only talk about the issue but also resolving it as much as possible.
Okay, so thank you. Thank you so much, Darren, Luzette, and of course, Rani. So thank you for the very good discussion. We would see a lot of messages that we have in the chat box expressing their thanks messages to the panelists for a very excellent discussion. So we'd like to thank also our team of the digital events for this very important activity that we have today. So again, I'd like to thank you and thank our attendees and all those who have given their questions. So thank you so much.
Well, we
It's
thank you as
very
well.
enlightening. Yes.
Thank you, nice to meet you, and thank you for the invitation, Darren. I thought it was great.
Thank you all very much.
Thank you so much. Thank you. Nice to see you all. Thank you, Nor. Also.